Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a Her-2 positive invasive lobular carcinoma metastatic to the liver. So this is a case of a 62-year-old female patient who is known to have invasive lobular carcinoma in 2018. And at that time, the immunoprofile for the predictive markers was ER positive, PR positive, and Her-2 negative. Score zero. She presented with liver metastasis, and as you can see here, this is the liver, the normal liver, and this is the tumor infiltrating the liver. And in other focus that was totally replacing the liver tissue, an alveolar-like growth pattern was identified, yet the tumor cells were discohesive, and this is very important to establish the diagnosis, because this appearance might be reminiscent of a poorly differentiated ductal carcinoma. So the first thing that I did was GATA3 to prove that this is really coming from the breast, and this is the normal liver, and these are the individual cells strongly positive for GATA3, thus supporting that this is coming from the breast metastatic mammary carcinoma. Now, E-cadherin, this is the normal liver where we can see the membranous staining, and these are the tumor cells that were just highlighted with the GATA3 immunostain, and as you can see here, complete loss of the positivity of the membranous positivity. And this is also seen in the alveolar area that was reminiscent of ducts. Again, there is no evidence whatsoever of any positivity with E-cadherin, thus supporting that this is invasive lobular carcinoma. More so, beta-catenin nowadays is also used whenever you are in doubt, especially if E-cadherin was positive or focally positive in particular. The negativity for beta-catenin would support the lobular nature of the tumor. So the beta-catenin, this is the membranous staining that is seen in the hepatocytes, and these are the tumor cells, the invasive tumor cells, completely negative. And again, the area where we have the alveolar growth pattern, complete negative staining. There is loss of the membranous staining with beta-catenin. So E-cadherin negativity, beta-catenin negativity in highlighting the membranes are all both supportive of a lobular carcinoma, invasive lobular carcinoma. Now the ER, remember the ER was positive initially in the tumor that was diagnosed in 2018, and this is completely negative. Now normal liver hepatocytes are positive, show nuclear positivity with ER, whereas the tumor cells are completely positive, completely negative. And this is the area of the alveolar growth pattern, and the ER is completely negative. So this is really contradicts what was the immunoprofile for ER in the initial tumor in 2018. PR was only focally positive in the tumor cells, and also was like less than 5% weak positivity in some of the tumor cells in the alveolar area. What was really surprising was that Her-2 was positive. So this is the normal liver, and these are the individual cells that were highlighted with the GATA3 that were negative with E-cadherin and beta-catenin, and that were negative with ER. Now beautifully showing this score 3 positivity with Her-2, and also this is the area of the alveolar growth pattern of the tumor, showing this decoration of the cell membrane with Her-2 positivity, confirming the score 3 positive staining pattern. So to sum up, initially the patient was diagnosed with invasive lobular carcinoma in 2018 that was ER positive, PR positive, and Her-2 negative, which is the typical staining pattern for invasive lobular carcinoma. Whereas when she developed the liver metastasis now, 5 years later, the diagnosis is confirmed to be invasive lobular carcinoma metastatic with the E-cadherin negativity and the beta-catenin negativity. However, there was a change in the immunoprofile for the predictive markers where ER became negative, PR showing only this scattered focal positivity, and more importantly, the Her-2 now is score 3+. Now, this phenomenon of change or discordance between the primary tumor and the metastatic tumor in invasive lobular carcinoma is well described in literature. In particular, some of the tumors in up to 20% of the cases of invasive lobular carcinoma, up to 20% might show loss of the initially positive ER positivity, and up to 5% of the cases might show gain or amplification of the Her-2 score, which means that those patients would benefit from treatment with anti-Her-2 treatment like Herceptin. So this is why it's extremely important to remember that in occasional cases, despite the morphology and the immunoprofile of lobular carcinoma, still ER can be negative and Her-2 can be positive. And it's important to remember that regardless of the initial immunoprofile, there can be changes in the immunoprofile in the metastatic setup, in particular loss of the ER staining and thus loss of the response to hormonal treatment, with gain of Her-2 positivity in up to 5% of cases, which means that patient would really benefit from targeted treatment. I hope you find this tip useful in your daily practice. Thank you.